In today's video, you are going to learn 15 principles to optimize your brain's ability to rewire after a neurologic injury. If you're new to this channel, I'm Tara, I'm a neurologic physical therapist, and on this channel we talk about anything and everything related to mobility, health, fitness, and mindset with the end goal of empowering you with as many tools as possible to take full ownership of your rehab and your overall health. And I can't think of a more important topic than what does the evidence say are the most essential components that you should be incorporating into every single one of your exercise choices in order to be able to optimize your brain's ability to rewire. So in today's video, you're going to learn about neuroplasticity, kind of what this term means and why it's an important term to understand following a neurologic injury. The 15 principles that are kind of new-ish, based on years of evidence of researching best interventions after a neurologic injury. And of course, a little bit of my experience and what I think are the best strategies to take these principles and immediately apply them to how you are designing your home exercise program. First, let's just talk about this big fancy word, neuroplasticity. What does this mean? Neuroplasticity, again, is just a fancy word that is your abilities or your brain's ability to rewire or reorganize with repeated use and practice of specific activities. Now, the million-dollar question for years and years and years is, what are those specific activities that you need to repeatedly do in order to get your brain to heal or rewire around damaged areas after any type of an injury to your neurologic system? Now, the article I'm going to be going through today, it's not new. It was published in 2019, but it is important to know that this was specifically looking at evidence or research that was performed with patients that had suffered a stroke. So I know we have a little bit of a broader audience than that, but just keep that in mind. I do think that based on my experience, these principles do apply, whether you've had a stroke or whether you have an injury due to multiple sclerosis. But it is important to know that these principles were based on evidence or research that was performed on patients that had had a stroke. Okay, so back to that million-dollar question. Before we get into what is the best exercise, which again is the million-dollar question in stroke rehabilitation, it's good to just give a little bit of context on what the history has been with the study of interventions after a stroke. Now, back in the day, not too long before I started in physical therapy, which was 22 years ago, so fairly recently, they thought that after a neurologic injury, if you were an adult, your brain did not rewire. It was not possible. The best chance you had at restoring some sort of normalcy after a neurologic injury was just to train the side of your body that was not impacted to do everything for the side of your brain that is now damaged. In other words, teach you how to do everything with one arm and one leg, because the damaged side of the brain, there was no possibility of that side of your brain reorganizing. Now, thankfully, in the last 20 years, they've done lots of studies since then, and we know that that's just not true, that your brain does reorganize and can recover after a neurologic injury. It's a little bit different than normal childhood development when our brain is wiring for the first time. And it's not as easy for the brain to do this after you've had a neurologic injury as an adult, but it's not impossible. Interesting story or fun little side fact. My first job was in a facility that just treated patients that had had a stroke, or that was the majority of the patients that were treated at the center that I first worked at. And I came out of school first year, rearing to start implementing the things that I had learned in school, and everything, for the most part, that I had learned in school, and this is just a little over 20 years ago, was to teach people how to compensate, lock your knee out because you weren't going to be able to support your body weight on a bent leg. And I was enthusiastic about implementing those strategies. And my boss at the time literally came into the middle of one of my treatments because we all treated in like a big gym. She kind of intervened and showed me some nice little manual cues to do to help facilitate movement and not just teach someone how to compensate. So I would say around that time in the rehab world, the pendulum had swung a little bit from let's just teach someone how to compensate to let's teach someone how to reorganize or rewire their brain or by normalizing movement patterns on the affected side. And I will say for a subset of neurologic physical therapists, the pendulum swung way the other way. And now it was all facilitation for a group of neurologic physical therapists, pretty large group, and that you shouldn't do anything if it caused someone to compensate. So put the brakes on anything that was considered like compensation, and you should strictly be facilitating movement on the involved side. Just stick with me because this is all important to understand why different therapists have different viewpoints, and we're not confused and one therapist isn't right and one therapist isn't wrong. It's just that there is a mixture of opinions on what is best. But I think this article does a good job of kind of bringing those two worlds together. That's why it's so important. Okay, so we swung way the other way, and now it was all facilitation and don't allow anyone to compensate. And they did some studies on that. And what they realized was that teaching someone how to facilitate movement on their damaged side, there wasn't a lot of carryover, meaning that they weren't getting functional recovery. And I agree with that because having someone just sit on a mat and facilitating perfect movement and not allowing anyone to do anything outside of that is not ideal, which we're going to get into today when we get to the present day, what those principles of neuroplasticity are based on all of these years of research. And we entered into a new area of kind of like robotic training. And this was going to be the greatest thing since sliced bread. We were going to put people on a treadmill. We were going to put an exoskeleton on them, i.e. a robot. And we were just going to have them walk, 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 walk. And there was some evidence that this was a really good approach at decreasing someone's risk of falls and increasing their overall function. But what we had deviated away from was any form of like normalizing movement. Yeah, it did come as kind of like a side benefit for some people, but that's not what they were looking at. They were just looking at the robotic component and the repetitive, intense practice of just putting someone on a treadmill and having them step. But now the profession kind of took off in this direction, and they did a bunch of more studies on like, what is it about this high intensity walking? And is this the way that we should be going? They did a ton of studies, and they decided that, yes, this is the way that we should be going. The faster someone can walk, the better off they're going to be after a stroke in the long run, because you're going to have a decreased risk of falling. And they looked at other metrics, and yes, you had overall better function, meaning you could perform your activities of daily living at a little bit of a higher level than someone who hadn't done this intense body weight supported treadmill training. Downside of that is that now you had completely moved away from trying to normalize movement. And if you just work on getting someone to walk fast, they are going to compensate. There is no way around that. Okay. And so that's where I started to kind of deviate away from that train of thought. And yes, at one point I did work for a facility where I worked extremely hard to get one of those robot assisted treadmill training systems in the hospital because they were really expensive back in the day. Huge advocate of it. But I didn't like the way the profession was going, that now we shouldn't work on anything else. We shouldn't work on quality movement at all. And we should just teach someone how to walk faster. And that's pretty much where our profession is at right now. And that's kind of what kind of led me to like start this YouTube channel, is people were just going to therapy and all they were getting was high intensity gait training. They were seeing me like 3, 4, 5, 10 years, into this type of training that they'd been doing. They have all these compensatory mechanisms. They're locking their knee out, they're hip hiking, they're circumducting. Now they have all kinds of issues, not to mention wrist issues and shoulder issues on the uninjured side because they're putting so much pressure onto an assistive device. And I just felt like that was going down the wrong rabbit hole. So where have I settled? I've settled that all of that history is beneficial, in that there's components of each one of these eras that can instruct us on how to set up the best training program now based on what was successful in each of those studies. And that's what the article did that we're going to go through today. What they did was they did a meta-analysis on the previous, I think, 10 years of research. They excluded a bunch of research on recovery after a stroke. They excluded anything that was like a pharmaceutical intervention or a surgical intervention, and pooled together the research on robotics, the research on cognitive training and learning after a stroke, upper limb immobilization, aerobic training, which was a lot of that body weight supported treadmill training, constraint-induced movement therapy, which was a huge era of research on first patients after a stroke, and that's where you constrain your uninvolved side, and we'll get into a little bit of that in today's video. Music therapy, biofeedback, and then timing and dosing, which there's been a ton of research on there. Is there an optimal time? Is there an optimal number of repetitions, which a lot of you guys ask me in the comments and in our member Q&As. And based on all this evidence, they have come up with 15 principles that they believe are the critical components when designing a stroke recovery program or protocol. And I'm absolutely in love with the list that they came up with, because I've probably made a video on many of these things separately, based on some of the studies that they are now pulling into this meta-analysis. So just for example, if you've been around for a while, you know I've done one on imagery, visualization type of activities. I've done one on constraint-induced movement therapy, mirror therapy. A lot of those studies that I have read in the past have all been brought into this study to come up with these 15 principles. But more than that, practically, when I look at these principles, these are the things that work. And so now they've just kind of taken it all and they've brought it into one list. And that's what we're going to go through today. So first, the key findings in this study were big picture, and we know this, these are things that no one really disagrees on. Experience-dependent neuroplasticity drives recovery. Experience-dependent neuroplasticity. When you practice something repetitively, the brain will reorganize. That's what that means. There is a need for structured stroke rehabilitation. Hallelujah. And if you don't know how huge that is until you understand that there was a time where they just thought the brain spontaneously would recover as much as it could, and there was nothing you could do outside of that to change that. So this is something that we haven't really disagreed on in a really long time, but I'm just glad to know that it's now written down. The importance of integrating motor learning principles. So you guys hear me talk about motor learning principles quite a bit. I've done a few videos recently on brain healing or brain recovery, where I also touch on those motor learning principles. And I will link those videos in the description below. To me, this is a no-brainer, but it is something that a lot of physical therapists miss. Big picture, all that means, like motor learning principles, is that there is like a cognitive phase where you get a lot of feedback, and either by a therapist or a family member. And that's kind of when you're starting to learn an activity. Then you kind of go into a phase where you understand kind of how to recognize some of the errors in your movement, and you're able to correct that. This is just big picture simplified. Then you go into a phase where it becomes a little bit more automatic, where you don't really need to think a lot between recognizing that you're making an error and making that adjustment or correction. And only then and after then can you generalize that task or that one activity to other activities. That's extremely simplified and extremely brief, but that's what we mean when we're talking about like motor learning principles. They do think that that's a very, very important component of assessing where someone's at, but also giving someone the right activities at the right time. That's just big picture. Now let's get into those underlying principles. And the first few have to do with motor learning strategies. A big component of motor learning strategies, so relearning a movement activity, is what we call practice schedules. Practice schedules are basically just what is the skill and kind of how do you structure how you do that skill. The first one is called repetitive practice, and that just means you do a motion over and over and over again. And many of you know this because we talk about repetition all the time. But where it gets into a little bit of more of the nitty gritty is what type of a skill do you do that repetitive practice with? And there's two ways that we do this in physical therapy, and there's pluses and minuses to both. And this is what I see clinically as well, but they're just kind of highlighting it in this article, is there's mass practice and block practice. So mass practice is when you do an entire skill and you do it over and over and over again. So, for example, you do a transfer. So you stand, transfer, sit, stand, transfer, sit, stand, transfer, sit. That would be like mass practice. Then there's something called block practice, where you break that skill down into its components and you work each one of its components separately. So maybe you do partial sit to stand, partial sit to stand, partial sit to stand 1,000,000 times or 50 times. And then you move on to, and you do the stand, and then you do standing step pivot, where you're just working on the standing component, and then you just work on the sitting component. That's called blocked practice. And there's been debates as to which one is more important. And as this article highlights, and what I've seen and what I kind of preach, is that there's pluses and minuses to both, depending on what stage in the recovery process you're at. So if you're in the earlier stages, in my opinion, block practice is effective. And this article confirms that based on them looking at a bunch of other articles, is that block practice is really good at acquiring a skill, meaning just working those components. Remember that transfer example I use, you just work sit to stand until you get that, or you work that on its own, you work the stand pivot on its own, and you work just the sitting component on its own. That's really good at learning the skill. But it's really good at performing the skill and initially acquiring the skill, but it's not really good at retaining that skill long term, which of course we do see that, or I see that in practice. So that makes sense to me. And then there's mass practice, which is you do the entire skill together, transfer without breaking it down. And that's good, but that does impact performance, which also makes sense, meaning that if you just put the entire skill together without breaking it down, you're going to see some degradation in someone's ability to perform that skill. Now, how do you know which one to do? Well, the way that I do it, so this is just based on my clinical experience, is you guys have heard me say this before, but if we try something 3 times and you failed 3 times, that's when you need to start breaking it down, because A, you're just going to get frustrated, but B, you're not really learning anything anyway, because you're making a lot of errors. So your performance is not great. But the point is the principle in and of itself is setting up the appropriate practice schedule for neuroplasticity. They do think that is an important part. And then there's something that we call like spaced practice, where there's a time interval in between the sessions. And they do think that is, and this is what I see clinically, that is important for learning, that you do have to move away from it for a period of time and then come back to it in order to retain that skill long term. The other benefit of it is it does give you a little bit of a rest break. So they think that that's part of the reason why spaced practice is effective in learning and retaining a skill. And then the other component, just based on like the motor learning strategies area of the research that they looked at, was that dosage matters and frequency matters. Now, this is going to be very dependent on where you're at in the recovery process. Many of the studies they do, just because it's an easier type of study to do, is in the time period where someone is still in rehab. And again, that's really just because that's the easiest way to do a study, because everyone is there. All of the subjects that are being studied can be in one place. And again, this is important that they have written this down because this affects insurance and reimbursement, and the length of stay in rehab has changed dramatically. Right before I came into physical therapy, or right before I started working in inpatient rehab units, I heard that it was like normal for someone to be in inpatient rehab for like 6 months. That's no longer the case. The nice thing about that is you get therapy every day when you're in inpatient rehab. Now, I have views on whether or not being institutionalized for that long is really beneficial in the long run, but when it comes to getting the amount of therapy that you need, there might be an upside to it in this respect, and in this respect only. I think there's a lot of downsides to being institutionalized for that long, as far as your overall recovery, your mind, your mentality, your mood, things like that, getting sunlight, a bunch of other things. Also, having other people around you at all times to do everything for you, I think can be counterproductive in someone relearning how to do things for themselves. But they did, and this is based on previous research studies, they learned that a minimum of 2 hours per day was required in the first 6 months to get functional gains. And I think this research is already kind of common knowledge because insurance companies are probably the last to catch on to these things. And acute inpatient rehab facilities, that is the minimum requirement for reimbursement on one of those settings, is that you have to show that someone's getting 3 hours of therapy a day. So I don't think that's anything new, but I will tell you the reason it's important is many of you don't qualify to go to acute rehab right after surgery or right after your stroke, and you end up in a skilled nursing facility, and they try and incorporate that same kind of policy to get 3 hours of therapy a day if you're in the acute phase of stroke rehabilitation, but it's very hit or miss, and it's not a requirement, or it didn't used to be when I used to work in that world. And so just know that there is a difference between a skilled nursing facility and an acute inpatient rehab facility. So if you are trying to advocate for a family member, really make sure you look to see which type of facility that they're putting those referrals out to. Acute inpatient rehab facility is absolutely essential, preferably one that has a stroke center attached to it, because they're also going to be what we call CARF accredited, which is a rehab accreditation that you would get for treating like stroke conditions. Facilities can apply for these accreditations, and they are pretty intense. I've been through it for at the facility I worked at years ago. I went through it twice with 2 different conditions, stroke and spinal cord injury, and it is pretty intensive. And they really do come in and they look through your charts and your programming and all of that. So a CARF accredited stroke rehab facility is beneficial if you are out there advocating for yourself or a family member and looking for facilities. That's one thing I would look for, is that CARF accreditation. Then the next kind of category of studies that they looked at were task-oriented approaches. And based on this group of studies, and again, I'm going to link this one article in the description below, and there are citations for all of these articles that they used to come up with this one article or this one meta-analysis. And task-specific training is absolutely critical, which no brainer, something you guys hear me talk about quite a bit. But again, glad that they took a bunch of studies, and this is what the really smart people and the scientists have concluded, is that you have to do activities that mimic the real life activities that you're trying to get back to. If you want to get better at walking, if I had to simplify it into one thing that you could take away from this video, walk. If you want to get better at typing, type. If you want to get better at writing, write. If you can't hold a pen, strap the pen to your hand. These are the types of questions that I get a ton with people that I coach. And I want to seem like I'm really smart sometimes, but some of the solutions are that simple. Whatever activity you want to get back, find a way to be able to do that activity. If it's writing, strap a pen to your hand. If it's eating, strap a utensil to your hand. Things like that, with the involved hand, of course. Task-specific training. The activities need to be goal-oriented. They need to be moving towards something or an activity that is your ultimate goal. Why? Because this is absolutely essential for motivation, and not just motivation like, oh, I'm motivated to get up and do my exercises. No, motivation for your brain to want to latch on to that new information and hold on to it and not let it go. That is the essential component. It is so, so important that you find something that is meaningful to you as your end goal. Now, if you don't have anything, a few examples would be eating, drinking. Why? Because those are critical for survival. If you live alone, and in my experience, I will tell you, the people that live alone get the most recover. They by far recover the most. And the reason is they are very motivated to stay living alone. So they will do whatever it takes to learn the skills in order to be able to not end up in a nursing home or an assisted living facility. So they are extremely motivated, and I can't help but think it goes back to a lot of research studies that they've done on the importance of goal-oriented activities for neural rewiring after a neurologic injury. Those people have very meaningful goals. And then under the kind of task-oriented approaches, that evidence is variable practice. Very, very important, but there is a time and a place for it. Variable practice is just where you take a movement or a skill and you apply it to different contexts. Now, again, they're saying that that's an important part to get that neural rewiring. I will caveat that and say it depends on the stage in motor recovery. Again, it goes back to that try 3 times, fail 3 times. You got to not do that again. You have to not do that a 4th time, because then your brain is learning how to fail, and that is not good for motivation. So try 3 times. If you fail on the 3rd attempt, stop that activity, find a different variation to do that. The variable practice would be one of those things where I'd pay very close attention to that. In those stages of motor learning, those normal stages, there's a lot of thinking that goes on how to execute a movement in the early stages. The very last stage is being able to generalize that to different contexts. So it really does matter where you're at in the motor learning process as to whether or not you incorporate a variable practice schedule, meaning that you're taking that task and you're applying it into a lot of different contexts. So, for example, if you're in therapy and your occupational therapist is having you reach for a ball and then she's having you reach for a cone, that would be variable practice. Again, time and a place for it, maybe not in the early stages though. But if you're someone in the early stages and you're trying to move on, absolutely essential. And then in the task-oriented approaches that they looked at, increasing the difficulty, obviously that is a no-brainer, is that you constantly have to be moving that needle. Your brain needs to feel challenged to a degree in order to want to reorganize. This is where working with a physical therapist in person is so, so, so valuable. I've created this online program, which I'll talk a little bit more about here in a minute, but I have an online program, and absolutely, I think it's a great supplement to in-person physical therapy. But the stuff I can accomplish with someone as far as adding those challenges in a safe manner to really force that brain to have to figure this new crazy movement out that seems a little bit scary to you as the person in a safe manner is absolutely essential. But if you are someone that's on your own, just know that you have to be pushing that needle a little bit and challenging yourself to more and more difficult activities in a safe manner. Next, we're going to get into feedback mechanisms. So they've done a ton of research on what is the best type of feedback. Feedback, very, very simplified, is basically any cues in your environment or around you that will help you or enhance your ability to perform a specific movement. That's an extremely simplified explanation, but that's kind of big picture. That's what they mean when they're talking about feedback. What combination of engaging your senses is optimal in order to relearn a movement, I guess would be another way to explain it. And probably the most important that we neglect quite a bit is you have to engage as many senses as possible. You want, in a controlled manner, as much feedback coming in so that your brain has a lot of data to work with, to process and spit out a motor activity. So there's hearing, there's vision, there's pressure sensors on your skin, there's pressure sensors in your joints, there's little sensors in your muscles. You want to be engaging as many of those things as possible. Now, why do I tell you all that? Is there's a couple of downsides to being institutionalized. One is you're not getting as much of that sensory stimulation that you would get if you were in your own home or out in the community. Also, every time you modify an activity, you are changing or maybe minimizing the amount of senses that are involved. So doing an activity sitting versus standing, or doing your exercises laying in bed versus doing them sitting up, it's going to be a completely different sensory experience. When you're sitting up, you're engaging more of your senses than, let's say, if you're laying down in a bed. That would just be kind of like one way of looking at it. You want to engage as many senses as possible based on your point of recovery. So again, this is going to be the caveat to everything, is it's going to be different for each person, but doing all of your exercises laying in bed, or doing, if you're in the early stages, not ideal. Doing all of your exercises in your home when you're safe to go out in the community, not ideal. Doing all of your activities on a hardwood floor in a room without any obstacles in it, good, but not ideal if you're safe to walk out in the community and add more senses. Okay. So the more senses that you're engaging, the more your brain is going to normalize or reorganize around that movement. Auditory cues, absolutely essential. I use them quite a bit. I've talked about it when it comes to walking and using a metronome, but it doesn't just have to be like a metronome. Anything that has a rhythm, it's a different part of our brain. Now your brain is just responding to that auditory cue, and simplified, it bypasses some of the motor planning areas, specifically in the basal ganglia. This is why we use music and metronomes so much with people that have Parkinson's disease, but it doesn't have to be just Parkinson's disease. When you are moving to the beat of something, it requires less motor planning. If you're a dancer, think about it this way. I'm so envious of dancers that can just get out there and make dancing look so easy. Like, I'm always amazed. Like, I would be thinking about each one of those steps. I'm a huge Dancing with the Stars fan, but there's just no way. And I just don't understand how they can do that. And it looks so easy. And it's because they're just moving to the beat of the music. They're not doing any motor planning. Okay. So we know that auditory cueing is absolutely, absolutely beneficial to rewiring your brain or reorganizing your brain, i.e., learning new movements. And then there's explicit feedback versus implicit feedback. Remember, we're still in this feedback category of research studies. We've talked about this before, but if you're new, implicit feedback is feedback that's more unconscious or automatic. So the example I like to give for implicit feedback is when you're teaching your child how to ride a bike, you just put them on the bike and you just push them until you get that bike up to a certain speed where you know physics is just going to keep that bike upright. And that child is just learning implicitly. They're not really getting a whole lot of like real feedback. They just know go straight and don't fall. That's pretty much all the feedback that they're getting. That's implicit feedback. You kind of give a big picture destination or big picture outcome or end result, and then you just let someone go. And you let their internal processors identify errors and self-correct. So with this type of approach, and I do use this quite a bit, and sometimes I use it and people get frustrated because they want a lot of feedback. And we just know, and I've done a video on this, that implicit learning is the most effective way to learn after a stroke, or implicit feedback. So not getting a lot of cues. putting someone in a safe environment, allowing them to make mistakes, correct, overcorrect, undercorrect, put walls around someone, maybe let them fall into a wall safely and something that doesn't cause an injury, and just don't give any feedback. Allow them to figure out or adjust using internal processors. That's implicit feedback. And explicit feedback would be giving someone specifics. Lift your leg, set your heel down, shift your weight. That would be explicit feedback. Both are good. I would say in the early stages of motor learning, implicit feedback is best. Actually, I take that back. Implicit feedback is best across the board. So if you come see me in person and I don't give you that little specific thing that your last therapist gave you, heel strike to toe off, I hate that. It's the worst feedback you could possibly ever get. That's just not how we learn to walk. Not only that, it's not accurate. You don't have to think about toe off. You don't have to think about push off, most of you, after a neurologic injury. I hate it. It's the worst cue ever. But I don't give a lot of feedback. I prefer like kind of an implicit feedback mechanism. But based on this article, both have their time and place. I would say explicit feedback is probably the most valuable, either in the very, very early stages or maybe like the very, very advanced stage, that time where someone just cannot do it. If it's a new skill, they just can't, they don't even know where to start. Giving some feedback, telling them how to lift their leg, things like that, it might be beneficial. But overall, implicit learning should be the default, or implicit feedback if you're a therapist. Implicit feedback should be the default. Now we're going to get into a category of looking at kind of the data or the research studies around cognitive learning and what they've learned from those studies that they think are good foundational principles to motor or neuroplasticity, getting the brain to reorganize after a neurologic injury. And one is, and this comes from a study that I did previously on the principles of motor learning, and that is kind of forced use. So the default after a neurologic injury is going to be to compensate. So if you force someone to use the involved side, the brain will reorganize. And I will go so far as to say in the early stages, the brain is not going to reorganize if you don't do some form of forced use of the involved extremity. A lot of the research that they used to make this a principle in this article, it comes from what we call constraint-induced movement therapy. And that's literally where you constrain one arm and you force someone to do everything with their involved arm for a certain time frame during the day. Now, the downside of that constraint-induced movement therapy is it does have to be a specific stage in the recovery process. Someone does have to already have a little bit of movement. And then most of the studies they did, people were in that constrained state where their working arm was constrained for like up to 6 hours a day, which for most people is not ideal because you're not going to be able, there's a lot of things you're not going to be able to do during that 6 hours. But just know that forced use of the involved arm and leg is absolutely essential to get the damaged side of the brain to rewire. Now, what does this look like with the leg or some of the things that I do with physical therapy is something to get the other leg out of the way, whether that's working on sit to stand and setting the other leg on like a skateboard so that that leg is not going to help you if you put weight on it. If you guys have been around for a while, anytime I make a video where I bias the weaker leg, that would be some variation of forcing you to use the involved leg. So go through any of the videos that I've done on standing or single leg standing balance. Anytime I say we're doing this setup, setting the other foot on a yoga block or anything like that to bias the involved leg, that's somewhat of like a forced use. And then the other principle is observation, observing other people doing the activity. In part, this has to do with like mirror neurons. You know how when you're watching someone and if you're standing in front of them for a while, you just kind of start to take on their mannerisms. That is what we call these mirror neurons. And so they're saying that like that is a very helpful component. So watching someone do the movement is very, very beneficial. But where this also comes into play is like with mirror therapy. And I've done videos on mirror therapy. Mirror therapy is where you take the arm that's not working well and you kind of hide it and you put a mirror next to the arm that is working well and you have someone do stuff with their uninvolved hand. That's kind of what they're seeing is a reflection of that arm in the mirror. And that's kind of getting into these mirror neurons a little bit. And they've done these studies and they know that that is beneficial. So it's that body of research that they're using to kind of come up with this principle of observation. But that's also why many of you ask, there's a couple of reasons why I don't have patients demonstrate these exercises. One is that I don't want to take away from the therapy time that I'm spending with patients that are paying me to do physical therapy with them. But the other reason is I want you to see how a movement is done correctly. Now, that doesn't mean that someone that's had a stroke can't do that movement. I just want to make sure that what you're seeing is that movement done correctly. Okay, so that's the other reason that I don't really show a ton of videos using patients demonstrating the exercises. So again, observation, observing someone doing the movement that you want to restore, absolutely essential. And then visualization practice. Very, very important. They've done this with athletes, but they also have done this with people after a stroke. And when you're visualizing something, a lot of the same areas of the brain light up. Now, I will give you an example. I was a springboard diver in high school, and I will tell you, I know that this works in practice because I remember as a kid or, in my teen years, there was a moment where if I was trying to learn a new dive, once I visualized it, I knew I'd get it in the next couple of weeks. Until then, if I couldn't really visualize where my body was in space, there was this moment where all of a sudden I could visualize what I was seeing in my mind, like as I was going through it. And within a couple of weeks, I would get it. So that's just an anecdotal experience, but it does work with athletes. And now fast forward to working with patients that have had a stroke. Patients have told me like once they knew they could do it or they could visualize it in their head, they were able to do it. So never stop visualizing yourself walking normally, lifting a brush to your head, brushing your teeth with your involved arm, putting a jacket on, visualization. A lot of the same areas of the brain are lighting up when you do that. Now, will it replace it? That would be like those, shakers back in the 70s that they said you could just stand on and it would melt your fat away. No, there is no quick fix. There is no magic pill. You just can't sit around and visualize things. But during your downtime, when you're not in therapy, that's a perfect opportunity to spend some time visualizing. And then the last principle is social interaction. Being in a supportive environment, in my opinion, with other people who are going through what you're going through. I get it. Some of you are saying, I went to a support group and it was horrible. And I do understand that. There are stroke support groups out there that I have heard, just based on patient feedback, that they don't want to go to because they're just depressing. Well, find another one because they're not all like that. There are some very supportive, uplifting, positive support groups. It's absolutely essential. But as far as motor learning, the professionals that have nailed this are speech therapists. They do a ton of group therapy with speech or relearning like speech. And it is amazing. Like people just feed off of each other in those groups. I remember when I worked inpatient rehab, one of the speech therapists just had this like toy microphone that she used to pass around, and they used to do interviews and pretend that they were like sports commentators and stuff like that. And just being in that environment, man, people would say stuff in there that they would never say when they were just with me in physical therapy. So there is absolutely something to being in that group environment, in a supportive environment where you're not going to feel judged or anything like that. That is absolutely valuable. One reason I tell you that is because when you are with family and friends, if it does come to a speech therapy issue, talk, have a close group of friends. They don't even have to be people that have had a stroke that you can just talk with and dialogue with. So valuable with the speech therapy. But then also when it comes to like the physical recovery, maybe start in your community a little outreach group where you guys get together and you just do chair exercises, or you do something together, being in that supportive community. Or actually, I don't even think it needs to be stroke related. I did write some notes down, but I think of things when I'm actually talking of like, I've had patients that like they have a weekly bridge game that they go to, or, they have like a chess group that they go to, or one of my patients goes and like does like flower arrangements with some of her girlfriends, like even anything like that, like being in a supportive, encouraging environment. Those people that are engaged in those types of activities absolutely recover more. I'm just telling you. I know some of you maybe are a little bit less social, which I kind of fall into that category. But if I were in this situation and I had just had a stroke and I wanted to optimize everything and do everything I could to get my brain to rewire after a neurologic injury, I would absolutely be in a lot of groups where some physical, if it's like I'm a physical therapist, so we're going to stick in the physical therapy world, where some sort of physical movement was necessary or was part of that group or was part of the activities that we did with whatever that group is. So then what is the take home from all of this? We went through 15 principles. And again, I will link the article below. You want to design a therapy session using as many of these principles as possible. The practice schedule matters. Repetition matters. Visualization matters. Forced use in certain situations matters and can be beneficial. Doing goal-directed activities, being in a supportive group, all of that matters. So incorporating as many of these principles as possible. Little tangent, there will be a PDF handout that goes along with this video that's going to have all of these principles listed on it. Those PDF handouts are available to our gold and our bronze and our silver monthly members. Most of the videos here on YouTube do have a PDF handout that go with them if the video is within the last year. And again, all these principles will be outlined in a PDF handout. If you are not yet a member and you want access to that PDF handout, go to rehab-hq.com to become a member today. But the bigger take-home message that I got from this article is that neuroplasticity is absolutely 100% possible after a neurologic injury as an adult, and that coming up with a structured program is absolutely a make it or break it issue when it comes to restoring normal movement. Again, I do think in-person therapy, especially during the first 2 years, is absolutely critical. I just don't think there's any way for you to recover on your own in getting these foundational principles implemented into a home exercise program. But also, even during those first 2 years, just going to therapy once or twice a week is not enough. And that's why I have come up with my membership program, online membership program, where you will get access to all of the exercises that I give to my patients that I see in person. It's in a software system where you can create your own home exercise program so that every time you log in, your exercise program is there. You go through it, and then you progressively add more challenges to keep making that exercise program more difficult. If you're a gold member, you also get access to our monthly Ask Me Anything. I can answer your questions to fine tune it and make sure that your goal-directed activities are kind of aligned and incorporating as many of these principles as possible. You also get access to our monthly webinars, which not only do we go into many of the motor learning principles, break down movements and how to take something that maybe you're doing mass practice, meaning you're doing the entire movement, and how to do it more blocked practice, meaning how do you break that skill down. That's the type of stuff that we go over in the webinars, as well as everything you can do to optimize your internal environment, diet, nutrition, sleep. A lot of that information I don't even put on YouTube. A lot of that information is only in our member webinars. So it's a ton of content, and you're in a supportive community. So, which is another critical principle that we went over today that is essential to reorganizing your brain. So all in all, if you want to become a member, which again, I think it's super valuable, if you're in that first 2 years, to be able to do something every single day and not just the 2 days a week that you go to therapy. But if you're beyond that 2 years, really a way to keep you accountable and really give you an actionable plan to keep making progress if maybe your physical therapy benefits have ended, to learn more about those programs, or to schedule a discovery call where you can talk to someone to see which program is right for you. Please visit rehab-hq.com. But if you made it to this point in this video, I am so confident that you are on the right track. This was a long video, so it means you're super motivated and you have the attention span to relearn movement after your neurologic injury. So I am super excited for you and all the things that you're going to accomplish this year. But that is it for this video. I enjoyed spending time with you all today, and I'll see you in the next video. Have a good day.